Surgical management of the heart failure. So the most common cause of heart failure is myocardial ischemia secondary to the coronary artery disease. It presents acutely after the myocardial infarction as hibernating myocardium with contractile abnormalities due to chronic ischemia. The non-ischemic etiologies including congenital heart disease, valvulopathy, substance abuse, chronic idiopathic dilated cardiomyopathy, other types of cardiomyopathy, restrictive infiltrative processes such as hypertrophic obstructive cardiomyopathy, amyloidosis, and sarcoidosis. Patients are broadly defined as having heart failure with reduced ejection fraction and also known as systolic heart failure, or the failure with preserved ejection fraction, which is known as the diastolic heart failure. So, as we have discussed, there is injuries to the myocytes due to myocardial infarction, and the primary cause is the myocardial ischemia, which leads to electrical instability and reduction of ejection fraction, and there is a neurohumoral imbalance. So, the symptoms include dyspnea, fatigue, exercise intolerance that often go unnoticed due to their insidious onset. Patient may have then progress to unintentional weight loss, fluid retention exhibited by pulmonary congestion, peripheral edema, and ascites. Advanced heart failure may present as new onset of arrhythmia or cardiogenic shock. The etiology will also determine the acuity and the initial presentation. The most striking examples is acute cardiogenic shock following the territory of MI. So these are the grading of the heart failure. NYHA class 1 with no limitation of activity, with slight limitation it moves to class 2, with marked limitation it moves to class 3, and symptoms of rest are classified as class 4. Heart failure is a silently progressive disease and which is caused by various risk factors and leads to left ventricular hypertrophy and systolic and diastolic dysfunction and systolic and diastolic heart failure in the most advanced stage. So comorbidities that can affect COPD, hypertension, renal failure, diabetes, depression. Diagnosis of the heart failure is predominantly clinical and based on the symptoms elicited during or through the history and physical examination. The common physical exams include the pedal edema, elevated jugular venous pressure, displaced apex beat, S3 gallop. Further workup includes the labs to evaluate the renal and hepatic function as well as the serum sodium and albumin and B-type natriuretic peptide or pro-BNP or N-terminal pro-BNP. Electrocardiogram may show the evidence of ischemia or prior MI, but there are no abnormalities that are specific to the diagnosis of the heart failure. Patient with the frequently present with the new onset of the atrial ventricular arrhythmia, chest radiograph is useful to assess the presence of the degree of the pulmonary edema, pleural effusion, or pulmonary vascular congestion. Echocardiography is the mainstay of heart failure diagnosis as it can be used to evaluate the systolic and diastolic function. It is readily available and allow for serial observation to track progression of the ventricular function over time. When advanced heart failure is suspected, patients should be evaluated for the right heart catheterization to document filling pressure and the cardiac index. Finally, the exercise testing should be performed to determine the functional capacity and VO max. The patient are stratified based on the severity of their symptoms. According to NYHA classification, the diagnosis of the advanced heart failure is made when there is an objective finding of the cardiac dysfunction such as left ventricular ejection fraction less than 30%, elevated filling pressures, left atrial distension, pulmonary artery hypertension, peak VO2 is 14 kg, severe impairment of the functional capacity, NYHA class 3 or 4, fluid retention, hypotension, arrhythmia despite the optimal medical therapy, and appropriate device therapy. So for the diagnosis, risk assessment is carried out at the preclinical stage. Initial diagnostic workup in symptomatic patient, detailed workup in the case of uncertainty and underlying pathophysiology and etiology could be assessed by a cardiac angiography, SPECT, scintigraphy, biopsy, or cardiac MRI. So there are different features for the diagnosis of heart failure with ejection preserved and reduced ejection fraction. So symptoms of the heart failure are present, then biomarkers should be assessed, invasive hemodynamic monitoring, and that lead to diagnosis of heart failure with preserved ejection fraction. BNP is helpful in diagnosing staging, risk stratification, monitor and titrate the therapy, admission discharge decision, and to rule out symptomatic LV dysfunction. So the pharmacological therapy has been shown to improve the symptoms, slow the deterioration, and reduce the mortality in the patient with congestive heart failure. First-line medical therapy includes angiotensin system inhibitor, beta blocker, and diuretic therapy. Refractory symptoms warrant tailing of alternative angiotensin system inhibitors, hydralazine, digoxin, mineralocorticoid receptor antagonists, and the patient who remains symptomatic despite optimal medical therapy are candidates for chronic intravenous inotropes and vasodilators. The cardiac resynchronization therapy with or without implanted cardiac defibrillator is recommended in NYHA class 2 to 4 symptoms with left ventral branch pattern QRS with width of 130 milli equals per second with left ventricular ejection fraction less than 35%. So for the stage A of heart failure progression at a higher risk but without structural heart disease, stage B is structural heart disease but without signs and symptoms, stage C is disease with prior or concurrent symptoms, stage D is refractory heart failure. So the options available for the treatments are diuretic, CCB, beta blockers, ACE inhibitors, ARB, MR antagonists, ivermectin, digoxin, and HISDN and ARNIs. So diuretics usually relieve the symptoms and signs of congestion. ACE inhibitors for ARB, if not tolerated, we can add a beta blocker. Still in NYHA class 2 to 4, then add MR antagonists and continue disease management program. So we have to analyze the heart failure, look at the ejection fraction, look at the rhythm, and ivermectin could be added. And this is when we consider ISDN therapy. So diuretics are there to control sodium and water retention. CCBs improve exercise capacity and management of underlying disease, adequate treatment of hypertension, myocardial ischemia. So the management of the heart failure involves multidisciplinary approach, should target the high-risk patient and should include the competent and professional educated staff and multi-discipline approach. Now, if the patient develops atrial fibrillation, then it can aggravate the symptoms depending on the rate control. So here we have highlighted the role of natriuretic peptide, vasodilators, vasoconstrictors, and the role of beta blockers and ACE during that. These are the few current guidelines for the therapy, including the angiotensinogens, valsartan, ANP, BNP, CNP, and other vasoactive peptides. So, surgical management, the heart transplantation remains the gold standard for the surgical management of the end-stage heart failure, but it continues to be limited by the shortage of organ donors relative to increasing number of potential recipients. For the patient who present in the acute cardiogenic shock, there are a number of the short-term mechanical circulatory device support that can augment ventricular function with a causative lesion is identified and treated with a decision is made for the proceeding with the heart transplantation or longer term MCS. The long-term use of mechanical circulatory support has rapidly expanded due to improvements in the left ventricular assist devices. And the indications are bridge to transplantation, eligible patient for bridge to decision. If eligibility is still being determined, then destination therapy for transplant ineligible patient. Percutaneous therapies are temporary implanted devices can be used as a bridge therapy to recovery from the insult causing the cardiogenic shock. The recent changes in the organ allocation policies have dramatic impact on the implant strategy. Since their implementation in the 2018 under the new policy, the patient requiring ECMO or non-dischargeable mechanical support are given preference in other to decrease whilst awaiting the management. So 70% of the LVADs placed since the policy change took effect have been for destination therapy. The indications for the short-term mechanical support include the cardiac arrest, myocardial infarction, post-cardiotomy shock, acute myocarditis, and cardiomyopathy, high-risk coronary intervention, or refractory arrhythmias. They are typically considered BRT or BTD. The most common used short-term devices are intra-aortic balloon pumps, percutaneous ventricular assist devices such as Impella or Tandem Heart, VA ECMO. There is a limited data to recommend one device over the other, so decisions based on indications, availability, intended duration of support. Contraindications include irreversible neurological injury, systemic illness and survival, disseminated malignancy and severe peripheral vascular disease, and contraindication to anticoagulation. Indication for long-term MCS include the advanced heart disease that is relatively refractory to OMT and causing poor quality of life and organ dysfunction, inotrope dependence, cachexia, and low aerobic activity or 6-minute walk distance less than 300. And these patients should be referred for the heart failure specialist considered for the heart transplantation LVAD concurrently. The decision to proceed with LVAD therapy must be agreed upon the multidisciplinary heart team, and it's imperative and the patients have adequate social support outside the hospital prior to LVAD implantation. Careful review of the echocardiography for presence of the valvular insufficiency, patent foramen ovale or ventricular septal defect. Consideration should be given to the intra-aortic balloon replacement, and mitral or tricuspid valve repair is appropriate. Special attention should be given to the right ventricular function, as the right-sided heart occurs in 20 to 30% of the patient, and after LVAD may be predicted by normal CVP or RV or stroke volume. The temporary right ventricular assist device placed has been shown to improve the short-term outcome in patient at risk for RV failure and LVAD. First generation of the left ventricular assist device provides a pulsatile flow, and they are shown to decrease the mortality among the patients awaiting the heart transplantation. In the retrospective analysis, these findings have led to the landmark rematch trials, which compare the first generation LVAD HeartMate to OMT in the patients who are not eligible for transplant. Rematch demonstrated a significant survival benefit, leading to the LVAD approved for destination therapy as well as BTT. The refinements of LVAD design leads to second generation of the continuous axial flow device like HeartMate 2, and that could be made smaller and more durable because it requires a fewer moving parts. Further refinements leads to development of the centrifugal flow hardware HVAD, and HeartMate 3, as well as time for this writing. The HeartMate 2, HVAD, and HeartMate 3 are only devices commercially available in the United States. Survival after implantation of a continuous flow LVAD exceeds 80% at first year and 70% at the 2 years, which are comparable to heart transplantation outcomes at a similar point. Patients managed by BTT have a higher survival than destination therapy, and 61% of the BTT undergo transplantation by 3 years. The most common complication of the GI bleeding is stroke, infection, heart failure. The bleeding after the placement of the continuous flow devices, multifactorial continuous flow, causes the development of arteriovenous malformation or the mucosal surfaces and the interface of the blood LVAD component induce coagulopathy. These factors, coupled with the need of the anticoagulation, explain why GI bleeding occurs in 15 to 20% of the patient. With the first year, an effort to reduce the anticoagulation must be balanced with the risk of the stroke and pump thrombosis. However, the rate of pump thrombosis associated with the HeartMate 3 in Momentum 3 trial has exceedingly low, and the rate of disabling stroke is 5%, and leading to speculation that lower INR goals may be possible. To research effort in determining the optimal anticoagulation strategy are ongoing. The infections are most common adverse effect occurring in 40% of the LVAD patients in the first year, but reports vary based on how the outcome is defined, and the infections can be broadly defined as a device-specific pump cannula pocket driveline and device-related like bloodstream, mediastinum, and the non-device-related like respiratory and urinary tract. Driveline infections are usually treated with long-term suppressive antibiotic therapy in presence of an active driveline infection that does not adversely affect the outcome of the heart transplantation. Hope you have enjoyed the topic, and thank you very much.